Welcome, everybody. Thank you for joining us today for liposarcoma in the real world, challenges and opportunities. During this webinar, all participants should be muted during the presentation, and please remember that the information in this is not a substitute for your direct physician's guidance and care. My name is Christina, Director of the Liposarcoma Support Network. It's a program of the LifeRack Group, which is a nonprofit that has been around for 20-something years. But the liposarcoma organization has been recently built out specifically to dedicating to advocating for liposarcoma patients. I'm also a patient myself. I'm thrilled to introduce to you today our presenter for the day, Dr. William Tseng. Many of you may have already heard of Dr. Tseng and his work, or maybe even received care from him. Dr. Tseng is a surgical oncologist at the City of Hope in Southern California. He treats soft tissue sarcomas, and his approach to surgery is aggressive, yet balances safety and preservation of quality of life. Dr. William Tseng pursued his medical studies at the Northwestern University, followed by a residency at the University of California in San Francisco in general surgery and a fellowship in surgical oncology at MD Anderson Cancer Center at the University of Texas. Prior to joining City of Hope, he was the Associate Professor of Surgery at USC, where he was the lead for the retroperitoneal sarcoma surgery program. Dr. Tseng's approach is to reduce patient anxiety by contributing to a much better understanding of their disease and most importantly, offering hope. We are also thrilled to announce that Dr. Tseng has officially joined our medical advisory board for the Liposarcoma Support Network. His expertise and insights will be invaluable in advancing our mission to make a meaningful impact in the lives of liposarcoma patients. We're grateful to Dr. Tseng for joining us today and for providing his insights. I will turn it over to you, Dr. Tseng, and at the end, we'll leave a little bit of time for questions.
Thank you for that introduction, Christina. It really is a pleasure to be here this morning. I'm very excited and also very excited to join the medical advisory board and to see this liposarcoma support network form and develop. And I'm very excited to be a part of all this. So good morning or good afternoon, wherever, or good evening, wherever part of the world you're listening in on. And then also thank you to the audience for joining on a Saturday on the weekend. So I look at this as kind of a casual talk. Feel free to eat breakfast, lunch, or dinner, or if you're in your PJs getting ready for bed, that's fine too. Right. So let me share my screen. Okay. You guys see my screen?
Yes, yes, we can see it.
Okay, well, you can see the slide. You guys can see the slides, okay?
We can hear the slides, see the slides. I think we're getting some feedback that we can't hear you super well. I don't know if it's possible to lean in a little bit.
Yeah, here I'll try to. Okay. Yeah. Okay. Great. So as mentioned, so the title of my talk this morning is liposarcoma in the real world: challenges and opportunities. As Christina mentioned, I'm at the City of Hope National Medical Center in Duarte, California, which is just right outside of Los Angeles. So these are my disclosures. My other disclosure is that I am on Instagram, if that's considered a disclosure. I think several of you have followed me or seen me on Instagram, and feel free to follow me. I just anecdotally, I just met another sarcoma physician or sarcoma group who has 12,000 followers. And I don't have that many followers. That's not my goal in life. It's like just to kind of put things in perspective. Because my other disclosure is that I'm a surgeon, and what I mean by that in terms of disclosures is that I will be talking a little bit about medical oncology, systemic therapy, about radiation oncology, radiation therapy, And the disclosure is that I'm a surgeon, so this comes from a surgeon's perspective. So the real world. So I put this in my title, and I'm sure there's many definitions for the real world, and many of you may have different perceptions or implications of what real world means. Um, so real world, when I first heard the term, that was a TV show that, according to Wikipedia, was in 2014 or 2017. And that's not what I mean, obviously. But real world started to, the term, the use of real world is sometimes applied in the medical literature. And this is a paper from the MD Anderson group, led by Nita Samaya, which used the term real world for palbociclib, which is a systemic therapy in liposarcoma. So for the purposes of this talk this morning, real world to me reflects the daily experience that I have as a sarcoma surgeon, a sarcoma specialist, and also importantly, what I perceive as the patient experience in the real world. And what I mean by that is, we will be, I'll certainly show a lot of studies, a lot of data, a lot of academics, but that kind of gets you only so far. The data only gets you so far. And as all of us in the audience know, there's a lot more to just data and statistics. There's kind of besides the art of medicine and taking care of patients, besides the science of taking care of patients and medicine, there's definitely the art of medicine. So that's what I'm trying to get at when I say the real world. So the outline of my talk, we'll start off with an introduction to liposarcoma, and this will be to emphasize that it is a group of diseases, and it's also a group of diseases that is like no other. And of course, I'm referring to just within sarcoma. And that also gets to why I'm very excited and very happy to see that this liposarcoma support network is formed. Because it is a really unique group of diseases within sarcoma. Then we'll talk about treatment, which again will reflect my bias of surgery. Most of the talk will be focused on well-differentiated and dedifferentiated liposarcoma, but we will talk about the other subtypes, especially in the beginning. And then finally, I have some slides towards the end about opportunities in liposarcoma. The title of my talk is Challenges and Opportunities. I will say that my wife sometimes tells me that I need to be more optimistic in life. Look at the glass as half full rather than half empty. So that's why I thought I'd take our challenges that we definitely have in liposarcoma as more of opportunities to improve, to be better. And then that also includes my opinion, my 2 cents about what's next in the field, where the field is moving, and also where I think the field should be moving. So liposarcoma. So first of all, we'll take a little bit of a step back, just because I'm not sure the whole background of the audience members with you guys. So we'll talk about sarcoma 101, and just to get everybody on the same page. So sarcoma, soft tissue sarcomas, they're very different from other cancers. First of all, they're rare. I think everybody knows that. But compared to other cancers, there are no risk factors that we know of for the majority of soft tissue sarcomas. There are some MTNST, neurofibromatosis, but for the most part, there are no risk factors. There's no, like smoking is not directly related to development of sarcoma. And then also there's no screening. We don't have a mammogram or a colonoscopy that we could do to readily detect sarcoma. It also often is a very subtle presentation, as you'll see in one of the slides there. And then in terms of location, so sarcoma can occur anywhere in the body. And I'm not talking about the spread of sarcoma, I'm talking about the development, where it first shows up. The vast majority of, or a little over half, I would say, not the vast majority, but a little over half do develop in the extremity. That's the arms and the legs. About 20% do develop in the retroperitoneum or the back of the abdomen. For simplicity, you could think of that as the abdomen. But you can see it does develop anywhere in the body. And then it's also not organ specific. So in terms of medical specialties, in terms of surgery, for example, myself as a sarcoma surgeon, I would operate anywhere in the body that sarcoma could develop. I mean, within reason. Like I'm not a cardiothoracic surgeon, but we basically go where sarcoma goes or where sarcoma develops. So it's different from breast cancer where you have breast surgeons, from colorectal cancer where you have colorectal surgeons that operate on that specific part of the body. The most key part to all this is that there are many different histologic types. So the pathology can be really challenging, even for a board-certified trained pathologist, general pathologist, if they do not specialize in sarcoma. And then I also wanted to get everybody familiar with the term histologic type. Histology refers to how the tissues look under the microscope. You'll see some examples of that. But that's often how sarcoma specialists talk about the disease. We talk about it in terms of this histologic type, that histologic type, this histology. So just to get familiar with that terminology. And treatment, as you can see in the box there, treatment is tailored to the histologic type and the location. That's key. So again, sarcoma 101, this is on the left-hand side. These are names for different types of sarcoma. They're not all of them, but just some of them. And you can see that the word sarcoma is in the majority of them, of the names, but not all of them. And then on the right-hand side, I've listed different behaviors of the disease, what happens in the disease naturally, what we also call the natural history. And you can see it's very specific. And so this emphasizes the point of why it's so important to understand the heterogeneity of soft tissue sarcoma. For this group, well-differentiated liposarcoma, myxoid liposarcoma, just two examples of this unique group of sarcomas. They also have unique behavior. You can see no metastasis to fat-bearing area. So this is all to kind of get to emphasize the heterogeneity or the diversity of soft tissue sarcomas. I often use this analogy, and I've used this with patients, and I see patients in clinic to describe sarcomas, particularly new patients that have just learned this term sarcoma. So the analogy is that sarcoma is a little bit like wine. And the idea is that there are many different kinds of wine, and it takes a wine connoisseur to a wine specialist, if you will, to really know the differences between each type of sarcoma. That's the same thing as sarcoma and having a sarcoma specialist. So liposarcoma, again, is only one of many histologic types of sarcoma. So I guess you could kind of say that we can consider ourselves a group of wines. Liposarcoma is by definition a cancer of fat. It's a malignancy of fat. As far as we know scientifically, there's no clear relationship to obesity, diet, or genetics, which also means that if you eat a lot of fatty foods, it's not going to necessarily cause liposarcoma or prevent it, or there's no direct relationship with diet or any of these other things listed as far as we know. And this was a review paper. This is a table from a review paper that, in fact, Dr. Samaya and I put together when we were first at MD Anderson together. This was back in 2013. I know Nita gave you guys the first seminar, which I'm very excited, very happy that she could give you guys the introduction to this, to liposarcoma. But just to emphasize it again, so there are, again, it's a unique group of diseases, and there are at least 3 different subtypes. Sometimes patients will ask me, Is it 3? Is it 5? Like how many members, or what the number is. The way I look at it is there are definitely 3, but recently there's addition of a new subtype called myxoid pleomorphic liposarcoma. And it could be 4, it could be 5 if you count well differentiated or dedifferentiated. But the key point is that each of them have, each of the different subtypes have unique genetic changes. Don't spend too much time looking at the details of this overview, but they have unique genetic changes. They have unique clinical behavior, the way the disease behaves, or the way the disease progresses. And importantly, they have differential responses to therapy. Some are more responsive to therapy, some are less responsive to therapy. There's different therapies also based on the subtype of liposarcoma. So to simplify this, I thought I'd do this kind of more graphically and then with keywords. I think the keywords is I take inspiration from I do travel as part of my work and also for pleasure as well. And then recently I've been to Italy and I go to Japan frequently, and it often seems like it's keywords in terms of learning the language. It's a foreign language. Italian is still a foreign language to me, but just knowing kind of keywords kind of helps me get through day to day when I'm in Italy, for example. So I thought I'd do that for you guys here for liposarcoma. Well-differentiated, dedifferentiated liposarcoma, it's abbreviated WD and BD. Some of the key words to at least start to get familiar with is retroperitoneal, which means back of the abdomen, and extremity, which is arms and legs. MDM2, CDK4, those are the genetic changes. And then unfortunately, recurrence is a key word in liposarcoma, or in well-differentiated, dedifferentiated liposarcoma. These are histology images, by the way. So what histology images means is that these are tissue sections of the tumor. So this is what, if you want to think back to high school biology, when you looked at a slide under the microscope, well, this is exactly that. It's a slide of a section of a liposarcoma tumor. And this is what it looks like to the pathologist that's making the diagnosis. Another subtype, myxoid liposarcoma. Some of the key words to know are extremity, again, arms and legs. Round cell, which is a description of how the cells can look under the microscope. It actually implies that the tumor is more aggressive if there are round cells that are present. Myxoid is very sensitive to radiation therapy, and one of the key words, key drugs, is gandelis, which is also known as protectin. That is a drug that's particularly effective in myxoid liposarcoma. I put in gray there. There's a new, I guess we can call it a drug as well. It's more of a product. It's an immune-based product, or a T-cell-based product that recently got FDA approval. It's been spearheaded, quite literally, no pun intended, by Sandra D'Angelo and Memorial Sloan Kettering. Then there's also pleomorphic, which is much more rare. So all these are obviously rare. This is rare of the rare. And lipoblast is the type of cell that the pathologists see to make that diagnosis of pleomorphic. And then there's also, as we had mentioned, a new subtype that's being described called myxoid pleomorphic liposarcoma. And that is, it shows features of both myxoid and it shows features of pleomorphic, but it's thought to be different and actually behaves differently from myxoid and pleomorphic. Retroperitoneum. So retroperitoneum refers to the back of the abdomen, and anatomically, this is what it looks like. So we're talking about the back of the kidneys, the major blood vessels, the aorta, the vena cava. And also, there are organs, other organs and parts of organs like the colon, the duodenum, the head of the pancreas. Liposarcoma is one of many subtypes, or histologic types that can occur in the back of the abdomen or the retroperitoneum. In fact, it makes up the majority of them. It's 50 to 60%. But there are other ones like leiomyosarcoma as well. So retroperitoneal liposarcoma, initial symptoms when the patient first presents, they do tend to be vague or non-specific. So it could be something as simple as abdominal fullness, or it could be reflux or constipation. You know, that's something that many people have that has nothing to do with sarcoma or disease. You know, it could just be simply stress. So initial symptoms are often very vague and non-specific. It can also present asymptomatically. So patients can have their liposarcoma detected just simply because the CT was done for another purpose, like kidney stone, as an example. And then actually rarely patients will present with symptoms. So there can be compression of the nerve, like the femoral nerve, or in liposarcoma specifically, I would say that there is a certain percentage, maybe 2 to 3%. I don't think this has ever been quantified as far as I could tell, but there is a certain number of patients that will show up with fevers that are unrelated to infection, or the patient doesn't have any signs of infection other than that fever. And that's due to the tumor. The workup or what we do on the medical side for diagnosis of liposarcoma and specifically for retroperitoneal liposarcoma, the abdominal liposarcoma, is as you can see, there's a lot of CTs. There's in the slide and in the workup. It's CT with contrast. And sometimes MRI is done, but CT by far is the test that's done initially, and certainly what we use for planning for surgery. CT of the chest, if there's a potential for metastasis or spread of the tumor. And then importantly, the pathology. I've said several times already, hopefully you guys heard it due to the volume, but pathology is key. Pathology is key. And so biopsy is often very important. That's a needle biopsy. And the best way to do a needle biopsy is through CT guidance, which means the radiologist does a CT scan to help target the appropriate part of the tumor for tissue to send to the pathologist to make a diagnosis. So CT scans and needle biopsy. I put that star there, the red star, to say that sometimes needle biopsy can be omitted if the radiology of the CT scan looks very convincing for well-differentiated liposarcoma. But most of the time, biopsy by default, I definitely support biopsy. So as we start to talk about the different subtypes of liposarcoma in the retroperitoneum, the vast majority, there are some exceptions, including we see myxoid, but vast majority of the histologic subtype that we see is this one, well-differentiated, dedifferentiated. And a little bit of background about this. Well-differentiated is what we call low grade, which means that under the microscope, that when the pathologist looks at it, the cells are more well-behaving. They're not as aggressive looking. They're not dividing. And then the behavior of the tumor tends to be more indolent, more slow growing. In fact, you could make the argument that sometimes it stops growing. Sometimes we do see that it stops growing naturally. So it's kind of it's more of a slow growing, indolent, I think is a good description. And you can have tumors that are entirely well differentiated, as shown there by the diagram. Or you can have this situation where you have what's called dedifferentiated disease, which is high grade. The cells look more aggressive under the microscope, dividing, et cetera, et cetera. And it tends to be more, this does definitely, but definitely does make the tumor more aggressive. That's aggressive locally, that the tumor will start to invade into organs and structures. And importantly, it gives it metastatic potential. So metastasis or metastatic means spread to other organs, typically the lungs in this situation. It's not 100%, but it certainly gives it potential to metastasize, whereas well-differentiated does not metastasize. And I like to tell patients in clinic that it's kind of like a tumor within a tumor. That's what it literally is. But in reality, it's a spectrum from well-differentiated to dedifferentiated, a spectrum of aggressiveness. There are entities in the kind of in the middle, like there's I'm sorry to be throwing out all these terms all of a sudden, but there's sclerotic liposarcoma, a sclerotic well-differentiated liposarcoma, cellular. There's even this low-grade dedifferentiation, which sounds kind of like, very confusing, but they are out there and they're well described. And also what's interesting is that sometimes the tissue does develop, the tumor tissue itself does transform focal into other tissues like bone, muscle, and cartilage. This is what it looks like under the microscope, again, the histology, and there is a clear separation between the well-differentiated and the dedifferentiated portion. The genetic markers, so this is very, very critical, and especially for if there are people in the audience that where you're at the stage of initial diagnosis and you're not sure whether this is a liposarcoma or not, compared to a lipoma, let's say, which is benign. The key distinguishing feature, besides how it looks under the microscope, is this genetic test in the tissue that detects MDM2 or another marker to know is CDK4. These are not mutations, by the way. For those of you who are thinking about drug therapy, immunotherapy, these are actually normal copies of the gene MDM2 CDK4. They're just highly amplified, which means there are thousands of copies, whereas you shouldn't have. There's thousands and thousands, abnormally many copies of these genes. This is what it looks like on the CT scan. You could see a tumor within the tumor there, with BB within a WB tumor. And this is what it looks like when you actually section a tumor. Again, you could see a clear separation between the BD and the WB. So treatment, surgery. I'm sorry to have to show you this gross picture, if it's gross to you guys, but this is what I see on a daily or regular basis in surgery. But this is what the tumor actually looks like. It's a very raw image of what liposarcoma looks like and surgery. You could see that it takes up pretty much the entirety of the abdomen, or a good part of the abdomen. And in this case involves the colon, which is common. There are other organ structures, kidneys, that I showed in one of the previous slides, that are behind this tumor that the surgeon doesn't see right away. Without perseverating too much on this picture, what the point of me showing this picture is to show, to kind of start to imply how challenging these operations can be. And that's exactly what surgery for retroperitoneal liposarcoma is, very challenging. And there's no other way to say this. From primary disease to recurrent disease is very challenging. Other treatments that we have for this disease include radiation therapy. And in our field, we are moving more towards preoperative radiation therapy. So right before the surgery that's intended to happen, if you are going to give radiation therapy, that's when you should give it, as opposed to after the surgery. Systemic therapy, and I didn't want to spend too much time, and as I said in my disclosures at the beginning, I'm not a medical oncologist, but there are many different options for systemic therapy. By the way, just to clarify, I refer to it, many of us refer to this as systemic therapy. So it's a drug therapy. And the way I look at this is chemotherapy, which everybody knows what chemotherapy is. Chemotherapy is one category of systemic therapy, because we are fortunate that we have for liposarcoma, we don't just have chemotherapy, we also have immunotherapy. We have several options. We have immunotherapy, we have targeted therapy. There are also others in both clinical trials and kind of exploratory phases of other systemic or drug therapy. So again, chemotherapy is just one of many systemic therapies available. Surgery is the primary treatment for localized disease when it has not spread or metastasized. And at surgery, so as a sarcoma surgeon, we're treating this disease, I can tell you that it's a balance. It's a balance of good surgical technique. You have to be a good surgeon, especially for these challenging operations. But it's also very important, and you can see the scale is kind of tipped more towards biology. Biology meaning an understanding of the disease. So it isn't all just about cutting it out. And then if you're curious, in 2020, Allie Davis, who at the time was a writer, and she's now an improv comedian, and I'm very proud of her. But at the time, she wrote an article about me. It's still out there. You could Google it, but about me and how I prepare for these operations. And it is a little bit of improvisation. It's not all improvisation, obviously, but it was a very interesting article. It was a fun experience for both me and I want to say for Allie as well. So in terms of surgery for retroperitoneal liposarcoma, this is how I think about it, and this is how most sarcoma surgeons think about it. So you really have to think, is it primary disease, which is when the disease first shows up, initial presentation, or is it recurrent disease when the disease comes back? And then also, what is the intent? Curative or palliative to address the symptom? And you can see the lines, the pathways overlap. So first of all, let's focus on primary disease. So primary disease, that is when cure is, when it's the highest chance for cure. That's when you aim for cure. That's why you want to get the tumor. So the problem is with these complex operations, and I didn't want to go into the technical details of the operation. That's obviously not the focus of this talk. There are other, that's like talking to a restaurant or something, and the chef isn't going to tell you how they prepare the meal, the details of how the dish is prepared. But the point is, though, with surgery being so challenging, and part of it, the disease behavioral biology itself, not just how challenging the technical part of it is. The key is recurrence is unfortunately the major issue. Recurrence is high even after complete resection. So even after the tumor is removed completely, and that star is reminding me to tell you that this is at major sarcoma centers. MD Anderson, this one is data from Milan. This is a little outdated. It's 2008, but this is still somewhat, fairly accurate. But you could see for dedifferentiated disease, these are, if you're not familiar with this, these are curves, curves of probability curve of recurrence. And the point is that with if you have dedifferentiated disease in your tumor, at 5 years, the chances of recurrence, the tumor coming back, is 80 to 90%. In fact, when I was at MD Anderson, I don't know if they still say this, but some of the sarcoma specialists there would say that the disease almost always comes back, or always comes back. So in the United States, in terms of surgery, what we do, again, I didn't want to get into the details of exactly what we do at surgery, but what we do is a complete resection, which is it's agreed upon that you need to remove the tumor completely, not in pieces, not leaving any tumor behind. It's unfortunate that often happens with non-specialists, but the ideal to strive for, the goal is to get a complete resection, not in pieces, not leaving tumor behind. And if the adjacent organs and structures are involved, so we're referring to the kidney or the colon, if they are involved, then you do have to remove them. But the question in retroperitoneal sarcoma is how much should we resect, given that the disease always comes back? It's the question is often becomes, is it the margin? Like I have patients that will ask me, understandably, nothing wrong with this, but patients will ask, did you get negative margins? Did you get clean margins? For other cancers, very important, very important. But for retroperitoneal sarcoma, it's a little bit up for discussion, but that is kind of the discussion that was in our field, at least in 2009. And in Europe, in Italy and France, there was this concept of an extended resection. And this is still practiced in Italy and in France and in Europe. And that's removing adjacent organs and structures, kidney, colon, even if it's uninvolved, And this is put forth by Sergei Bonvalot and Alessandro Bronchi, both close colleagues of mine close friends of mine in Italy and France. But even after extended resection, recurrence is still a major issue. And so I keep on repeating myself that this is part of the real world of liposarcoma. And this is a figure where each of the curves that's shown there, the different colors, the different shapes, that represents a different histologic type of sarcoma. And you could see with dedifferentiated disease, the risk of recurrence at 5 years, this is the 2016 paper, a little bit more modern, a little bit more contemporary, but the risk of recurrence after surgery at major sarcoma centers is still 40%. Still about half of patients. Well-differentiated liposarcoma, which is the blue curve right there, is similar. It's a little bit lower, but it's still arguably fairly high. So what it comes down to, and this is the concept that Rafe Pollock, who used to be at MD Anderson, is now at Ohio State, this is the concept that he put forth where you have kind of two different approaches to surgery: standard resection, again, just removing the tumor completely, but not the organs unless they are involved, versus extended resection, which is a bigger operation. And what it comes down to is at the end of the, if your goal is to get NED, no evidence of disease, at 10 years, standard resection practiced in the United States, still practiced in the United States, may involve multiple operations to get you to the point of NED. Extended resection, which is a bigger operation, arguably is a longer recovery, may lower or at least give you more time in between recurrence, but it doesn't make the recurrence zero. And that's a point I wanted to emphasize. I'll say it again: extended resection does not make recurrence zero. And so as a result, patients still undergo another operation that this may be later to get to that, hypothetical 10-year recovery. Quality of life is very important, and this is one real world example. I know many patients, many of you, many of certainly my patients refer to this as scanxiety, where each CT scan that you get after surgery, you're really anxious because you're wondering. I'm anxious, not just you guys. I'm anxious to see, is the tumor coming back? Is the tumor coming back? What's happening to the tumor? So is there more that we can offer the patient? And the answer is, of course, yes. So the next few slides, I wanted to talk a little bit about radiation therapy and systemic therapy. So radiation therapy, so this is the best study that we have in our field. This is the best data that we have in our field. It's called the STRASS study, STRASS. This is the STRASS 1 study, by the way. This is a prospective, this is a clinical trial, and what they found was across all types of retroperitoneal sarcoma, not just liposarcoma, patients that received radiation therapy, RT plus surgery, versus surgery alone, they did not see, the study did not show any benefit for radiation therapy. So the chances of recurrence at follow-up was not any lower if you added radiation therapy to surgery. However, again, recognizing with my wine analogy there, recognizing the differences between the histologic types and subtypes, there was a possible benefit in specifically in well-differentiated liposarcoma. However, in high-grade dedifferentiated disease, and particularly the more aggressive high-grade dedifferentiated disease, there was no benefit. So you could see that it's very dependent on histologic type. There was a subsequent study that was not prospective, it was more retrospective, that confirmed the same thing. But again, I wanted to say this is the title of the talk, Real World. So you guys, at least those of you who are from the United States, probably know who this is and what this TV show is. So if you were to ask surgeons, name something that makes retroperitoneal sarcoma surgery harder to do, I would say that a good majority of them would say radiation therapy. So my personal bias is that radiation even if it can lower recurrence, and you could see in the previous slide that was 10%, so it's not a huge lowering or reduction of recurrence. If it's 10%, the challenging nature of the surgery to begin with and adding on radiation makes it even harder to do, even more dangerous actually. And then this is an example of what radiation can do to the skin. This is, of course, after surgery, you could see the scar there. But that's a damage that radiation can, not always, and I don't mean to be putting down radiation because there is benefit for it. But if this can happen on the skin, and in the abdomen, there can be similar damage to organs and tissues. You just don't see it. It's not as obvious because it's not on the skin. So even with radiation and with local control, metastasis is still an issue. So if you look at spread of the tumors, the risk of spread, this is dedifferentiated disease, grade 2, dedifferentiated disease, grade 3. It's also interesting to see grade 2 and grade 3, there's a difference. So they're both dedifferentiated disease. But it can be up to 30% in 5 years of spread. Well-differentiated disease, as we've said previously, it does not spread. So if your tumor is entirely well-differentiated disease, it does not spread at all. So this is what Strauss 2 is looking to study. Strauss 2 is ongoing. So Strauss 2 is an ongoing study, and it's looking at the potential or the benefit of chemotherapy. In this case, it's liposarcoma. There's also rhombosarcoma. But the drugs, chemotherapy that's specific for liposarcoma, giving it in the neoadjuvant or preoperative setting, followed by surgery. So it's the same kind of a format or same kind of trial design as Strauss with radiation, whereas this is with chemotherapy. So this is planned to finish accrual in about 5 years. I'm sorry, in total 5 years. It's probably kind of halfway through accrual of patients. Eligibility is primary disease, and in this case, it's dedifferentiated liposarcoma. It has to be the more aggressive dedifferentiated, the grade 3. So, kind of the one elephant in the room. We mentioned the word. We talked about it. Many of you in the audience are intimately aware of this. The one elephant in the room is recurrence, and recurrence is what I refer to as the real world. If you look in the medical literature, I'm not saying you need to, but if you look in the medical literature, the vast majority, 95% of what's published, what's studied is, at this point, is primary disease, not recurrence. But as many of you in the audience know, it's recurrence that's the problem that we see and we keep on seeing, no pun intended, for liposarcoma. So when you look at recurrent disease, so what is the intent? What are you trying to do with surgery? Well, you are still aiming for a cure, at least in my mind and most of the time. But unfortunately, cure is I want to say more elusive. Oftentimes it is, there's also a heavier consideration for palliation. Palliation doesn't mean hospice. We're not talking about it's the end of the line. Palliation means does the patient have a symptom, and more specifically, a symptom that's very distressing or severe. Is there something that we could do with surgery or with our treatment in the setting of the recurrent disease? And then, as I mentioned, we don't have great data, unfortunately, for radiation therapy and systemic therapy in the setting of recurrent disease. Currently, what we do in recurrent disease is extrapolated from what we do in primary disease or some of the concepts that we have in primary disease. We just really don't have great data. And then, as I said, unfortunately, that is that's what in the clinic, like for example, in my clinic, the vast majority of the patients are with recurrent disease. This is an example using the picture that I showed earlier. This is a patient. Tumor there in green in July 2018. We do a complete resection. We do a great job. We may have removed an organ, but this is what the tumor looked like. Recurrence happens 2 years later, and it's actually 3 tumors at the time. And it wasn't that the tumor was spilled during surgery. It wasn't that we cut through the tumor. We didn't leave any tumor behind, but naturally it's back, it's bigger, it's actually 3 tumors. We do surgery for that, and then as you can see in 2021, and that's only a year apart, and all of those other 3 tumors were removed completely. We also didn't leave obvious tumor behind. And you could see recurrence again and more tumors. And this is something, even though this example that I'm showing is actually, this is my patient and these are my operations, I'm not trying to say that I'm a bad surgeon, that I am, that maybe I'm missing all the tumors. Well, this is unfortunately the reality that we see across all the sarcoma centers, like whether it's MD Anderson or Morris Kettering, Italy, France, this phenomenon definitely occurs. But eventually it takes multiple operations and the patient is NEB. So without getting into too much detail, I know I'm kind of running close to time as well. I did have the honor and privilege to put together guidelines that's with 45 authors around the world for how to manage locally recurrent retroperitoneal sarcoma. And why this starts off as guidelines is just because we don't have great data, we don't have great studies, independent studies to look at recurrent disease. So this was literally 50 of us in a room, a virtual room, of course, but 50 of us getting together, discussing how we as sarcoma specialists, retroperitoneal sarcoma specialists, manage this complex situation. So if you look at liposarcoma from this document, there's a lot of detail to this, but basically my point is that there are very unique things to liposarcoma that many of you may know yourself as patients or as family members of patients, but that in the medical literature, it's not really well described or studied. What it comes down to is that in the real world for recurrent disease, and when I say we, that's sarcoma specialists, people that see liposarcoma or retroperitoneal sarcoma on a regular basis, we see this all the time. And I highlighted there in red 2 key features: multifocal disease and multiple recurrences. So as a kind of disheartening or discouraging as this sounds, this is kind of sometimes the dilemma. Like this is what we see, symbolized by the traffic lights there. Multifocality, I'll kind of go through these slides quickly. So it just refers to 2 or more tumors. This was a study that I did when I was at MD Anderson, looking at the past 20, 30 years of cases with retroperitoneal liposarcoma, and we found that it is pretty frequent, and especially at recurrence. There's also an issue of what we call outside field. That means the tumor first shows up in green. You do the surgery, you do a complete surgery, and a good surgery. Keep in mind this is at MD Anderson. But the tumor shows up in an area where you do not expect it at all. That's why we call it outside field. And this occurs, it's not that frequent, but it occurs in about 11% of patients in this series. And certainly in my own practice since leaving MD Anderson, I do think that is a very real, applicable, real world number, I guess. This is an example of what that is in one specific patient. And then so this led us to develop the hypothesis or the theory that in some patients, again, this doesn't happen in all patients, but in some patients, all of the fat in the abdomen, including the pelvis, it may be at risk of development. It doesn't have anything to do with the surgery itself. You do a good surgery, you remove it all completely, but the tumor shows up in a completely different location. It implies that all the fat may have the potential to develop disease, even if it isn't in the area of the surgery. And this is unfortunately, as I said, this is what we see in reality. It's not just a study. The other key issue that we see in the real world is multiple recurrences. analogy that I sometimes use, and this is borrowed by from Ray Pollock, who used this analogy. It's that it's a little bit like trimming the hedges, like cutting the grass, meaning you do have to every once in a while do surgery to cut the tumor out, to kind of reduce the grass, so to speak, to a manageable size, hopefully gone. But it is necessary to keep on doing it, because unfortunately it's very hard to completely get rid of it, unfortunately. So finally, I know I'm coming to the end. I'm sorry running over a little bit, but opportunities in liposarcoma. So first of all, opportunities and challenges. Go see a sarcoma specialist. This is something I very much believe in. And I applaud you guys. I'm very happy that you guys are attending this talk, because it means to me that you are interested in knowing more about this disease. And then I encourage you to go see a specialist. Outcomes are definitely better. And this is just trying to show that in the real world, at least in 2018, when Emily Tian studied this, the statistics for the United States is that unfortunately only 10% of patients do see a specialist for retroperitoneal sarcoma. 10%, that's pretty shocking. I mean, 90% do not see a specialist for something that's as rare and as challenging and complex as this disease is. So I think the answer is really awareness, and I don't know how big or how much to emphasize this, but awareness. And so I'm very happy that groups like you guys, like the Liposarcoma Support Network, are supporting this, and awareness, education, awareness on many levels, not just the patient, but the provider, and even more beyond that. In fact, I'm not as I said, I'm not like Insta famous or anything like that, but I've always thought, is there some way we could start like a hashtag movement of go see a sarcoma specialist? I'll put maybe Christina can help with that, or someone else. But it's definitely there's a real need, a critical need for this awareness of sarcoma, liposarcoma, and sarcoma just in general. These are some of the issues that I see. I know I'm running out of time. I don't want to harp on this, but these are some of the limitations or ways that we can try to get around these limitations of getting to a sarcoma specialist. One of the elephants in the room is insurance, but again, we don't need to spend too much time. I'm happy to talk after about this as well. So finally, just to shift gears just a little bit, just to shift again. Immunology. So this was in 2015, and in 2015, I was very excited. In fact, I published some of the initial papers that were looking at the immune response in liposarcoma specifically. And since then, we've studied immunotherapy in liposarcoma. We still use immunotherapy in liposarcoma. It's just that unfortunately, the excitement for immunotherapy is kind of died down in the last few years, because it doesn't seem to be as effective for this histologic type. That's a very broad overstatement, and it's something more that the medical oncologist can talk to you about. But I did want to present this. So this is a patient, dedifferentiated liposarcoma, surgery in January 2023, developed a recurrence. And this is a picture, since we're talking about Instagram. This is a CT scan image that I posted. And I know several, I don't know if any of you specifically are in the audience, but I had a lot of questions, understandably. What did this patient receive? Because what this shows, this is a CT scan that shows that the patient's recurrence, showing their recurrent tumor, shown there in red, with not surgery, but with systemic therapy, the tumor went away completely. There is a little trace of the tumor that you might see here, like kind of what might have been tumor back then. It's kind of non-specific, but with just therapy, the tumor went away. So what did the patient receive? And so this is what the patient received. It's ipilimumab and nivolumab are two immunotherapy drugs, and trabectedin or Yondelis is a drug that, as I said at the very beginning of this talk, that's what we use in myxoid liposarcoma, not well-differentiated, dedifferentiated, typically, historically. So this is kind of a novel combination. And in fact, I was part of this is a clinical trial. I was part of the paper that kind of initially described the first series of patients where they received two of the three drugs that are given are actually immunotherapy. So the reason why I didn't mean to be rude and not reply to all the questions about what the patient received. And I still kind of caution you, and I want to stay optimistic, but this is only one patient. And there are several patients that received the exact same regimen that had no response. And so I didn't want to get false hope up, I guess. I don't know if that's the right way to put it. But I just want to say with caution that this still needs to be studied more. We're very excited about this. And to be honest, the reason I posted this was because I wanted to see among the liposarcoma community if anyone else has had this type of response. And this is anyone in the world. I wanted to see whether it's this similar type of strategy, or if it's a different chemotherapy, or if it's a different drug therapy. I wanted to kind of gather together all of the patients that had a complete response to systemic therapy. And then we can really study them. We could study the tissues from those tumors to see what is there something we're missing. So that's the reason why I posted this. That is the answer. That's what this patient received. And I won't go through this, but this is just to show that in 2015, we had a case report of a patient with a rare situation called a cystic liposarcoma. We studied the immune system back then. I've since had one other patient with this situation who is disease-free for 5 years. And then in 2025, case report of 2 patients with a similar situation. And all of these patients do very well. And so it's a question of, is there a natural immune response? Is this representing a natural immune response to the tumor? So finally, opportunities in liposarcoma. So if you were to ask me, these are my 2 cents. I think we really need to study recurrent disease, because that is the real world. Recurrent disease. So that's where I think we should study. And I say that half jokingly after another slide in a second. So this is a trial design that I proposed to a major drug company. I'm not sure. I think because I signed a non-disclosure agreement, so I don't want to say the name of that drug company or the name of the drug. I changed it to MDM2 inhibitor. But unfortunately, that drug it wasn't shown to be effective. But this is what I proposed to them, and a new study, a new concept that I wanted to move forward. And we'll see if there's continued interest. But in my proposal, it was to study this drug in the situation of locally recurrent disease. We do surgery alone, surgery first. We give the drug. How much of the drug do we give? How long do we give this drug? Is it for multiple cycles, 3 times 3 times 3, to get stable disease? Can patients just stay on the drug indefinitely and not have to do surgery? So anyways, this is the concept that I put forth, and we'll see where this goes. So as I said, the 2 slides ago was kind of half jokingly recurrent disease. Some of the other areas that I think are very important to study in liposarcoma, and I'm saying this to my own colleagues around the world, but also to you guys to kind of give you a sense of where the field is moving, and also and to encourage you to encourage, if you're close to your sarcoma specialist, to kind of spread the word, I think. But recurrent disease, and I think systemic therapy is really, it's important, but it's also, is there a different approach that we should be doing? And when I say approach, it may not be the next newest drug that is being studied in a clinical trial, but is it a combination of different drugs? Maybe drugs that, like for example, trabectedin, that's used in myxoid liposarcoma, that's kind of repurposed in a sense for a different histologic type. Palbociclib, CDK4 inhibitor, is usually used in breast cancer. That was used in liposarcoma. So that's another example. It's a different approach to systemic therapy. I really think that we need better drugs for well-differentiated disease. So even though I said that well-differentiated disease is more indolent and slow growing, it is still a major problem as well. Even though it doesn't spread, it still causes a lot of morbidity. Surgeries can still be difficult, especially in recurrent disease, depending on location sometimes. But systemic therapy, is there something that we can give for well-differentiated disease? And also, what is the endpoint? Are we trying to stabilize the disease for as long as possible, et cetera, et cetera? Quality of life, patient, your experience. Again, I said that this topic is real world. I know I personally am very interested in your, as a patient, like in my patient's experience. Because it is a very unique disease. It's different from typical colon cancer, or I'm sorry to say it that way, but it's a very different disease. And I do want to point out one study that we did with, I did this with a medical student at USC at the time, where we incorporated, as a published paper, we incorporated a Facebook poll. So at the time there was a Facebook group that I was more active in, but I'm not that active in it now. And I basically polled all of the members, and it was, I don't know, 1,000 members, or I can't remember how many. But I polled all the members to ask a question that was relevant for the research, and we included that data. So that's an example of kind of working together. So it isn't just us on the medical side trying to find the next best treatment, all of us doing this in isolation. We should be working together to advance the field. Research outside of the box. And I really mean outside of the box, because it's always very frustrating to me to know that patients will ask me in clinic, they'll say, so I've known you for 6 years, 7 years. Do we have any new treatments in liposarcoma? And yes, we do explore new treatments, but do we have anything new that has dramatically changed the field? So the way I personally myself is I've shifted away from immunology. Not to say that I'm giving up on immunology, and there are other groups that are still studying this. But I'm looking for ways to really go outside of the box. And there's a collaboration with biomedical engineering, let's say, a totally different field, a totally different look at liposarcoma to see if we can really find a cure. This should always be clinical first. That's my bias. I think it should be inspired by the questions that we ask. The approach should be clinical rather than the other way around. So this is, of course, as you can tell, I'm very passionate about this disease. These are some of the mainstream media commentaries, like Los Angeles Times, for example. And I 10 year for the 10-year anniversary of Wendy Walk, and I'm very happy to be a part of Wendy Walk, and I thank Wendy Walk for their continued support. When I gave a talk at Wendy Walk, I said I fantasize about the day that surgeries for liposarcoma are simple, small procedures, and that recurrence is rare. And that was several years ago. That was, I think, 4 or 5 pre-pandemic, maybe 5, 6 years ago. I still have that dream. That as much as I like doing surgeries and I like challenging surgeries to an extent, I do wish that we can have very simple operations, and that more importantly, the recurrence is there. And as I said multiple times, I'm very excited to be part of this liposarcoma support network. I know it's a relatively small group, or well, hopefully even more bigger group, but very proud to be with you guys to work on this disease together. And lastly, that I'm a strong believer of giving patients hope, giving sarcoma patients, liposarcoma patients hope. So sometimes in the real world, we don't just follow what NCCN guidelines says. We don't follow just what we've done for the past 20, 30 years. It's not just that. We sometimes bend the rules a little bit just to give the patient hope. So let's build something amazing together. Let's build something amazing together. This can be all separate discussion, future discussion, continued discussion. For those of you who know what Zoolander is, I'm proud to say that I have a scale model of Zoolander. And also just to say that, and this is, he wanted to build a center for kids who can't read good. So this is what I'm kind of saying is that we need to build a center, we need to build a program, a movement, whether it's social media or whatever, all of it. And then also hashtag when I was in Italy this last 3 weeks ago, it was actually Milan Fashion Week, which was the first time that I'd been there during Milan Fashion Week, which is quite interesting. Okay, I'm sorry I went over time. Had a lot to say. Sorry for the audio, but thank you. Thank you very much.
Thank you so much, Dr. Tseng. We really appreciate it. And I don't, if you have 5 minutes, we had a few questions come in. I think that this ends at 10:15, so it's possible we'll get cut off, but we will upload this online. But we had a couple of questions that some of that were sent in advance and some that came in live, and we're hoping that you could answer them. I think one of as you talked about radiation therapy, I think that this patient is asking if you've seen a difference in heavy ion therapy or proton beam therapy shrink inoperable tumors. This patient has previously tried other systemic therapies like doxorubicin, Brightline, and trabectedin, as well as modulated radiation therapy. So just if you could chat about different types of therapy, radiation.
Yeah, the short answer is no. Unfortunately, I haven't seen any differences with specific types of delivery of radiation therapy. I know I've had several patients that have received it, but not enough consistently to say that it does make the tumor shrink more or surgery easier to do or local transfer slower.
And we had a couple that came in live today. Is the possibility of recurrence likely with all liposarcomas, not specifically retroperitoneal as discussed here?
So that's a great question. So sorry, forgot how it was asked, but local recurrence is not always the case for other histologic types. So for example, myxoid liposarcoma, which is mostly in the extremities, arms, and legs, with treatment, and that may be what's usually a combination of surgery. Oftentimes we do radiation in that situation. Recurrence rates are very low. I think another good example is even well-differentiated, dedifferentiated liposarcoma in the extremity. So not in the retroperitoneum, but the same histologic type in the extremity with good surgery. And it's interesting, it's the same surgeon that does both the retroperitoneal and the extremity. The recurrence rate is very low. So what I'm referring to is mostly retroperitoneal.
Makes sense. And there is a quick one as we think about dedifferentiated and well-differentiated. Does it apply to all subtypes? I think that you mentioned that they're like totally distinct subtypes.
What does what apply to all subtypes?
Does dedifferentiated or well-differentiated apply to all subtypes, or are they distinct subtypes?
No, it's distinct. It's distinct. The dedifferentiated, you don't see that in myxoid and pleomorphic. They're all independent, by the way, so they don't change into each other. Like you start off with well-differentiated. So well-differentiated can develop dedifferentiated. That's the one exception, what I just said. But that subtype, well-differentiated, dedifferentiated, doesn't become myxoid. It doesn't become pleomorphic. They're all independent subtypes. Now, it can get a little confusing though, because you can have a myxoid variant of a well-differentiated, dedifferentiated, which means it looks like myxoid, but truly it is not myxoid. It doesn't behave like myxoid. And just as we said, there was a new entity called myxoid pleomorphic that looks like the other two, but it's not that they change into each other. They just look similar.
We have one other question about your thoughts on integrated care supplements and its impact on long-term outcomes.
Yeah, it's a great question. I get this question all the time, and frequently think about this. I personally don't have any opposition to it, first of all. In fact, To a certain extent, I encourage it because we need better treatments, better ways of approaching this disease. As a field, we don't have any strong data that suggests any one alternative treatment or method of treatment or lifestyle would improve outcome or impact treatment in any way. So it's kind of plus or minus because it could make things worse too. Some of the alternative medications can increase risk of bleeding, which makes surgery harder to do. But at the same time, it might be that there might be some new what we call alternative treatment that very soon might become the main way we treat this disease. The cure might be in one of these alternative treatments. Trabectedin or Yondelis, I don't know how many of you guys know this, but it's interesting historically. Trabectedin is derived from a Caribbean sea squirt. That's like a sea sponge or a sea urchin, basically. So that's where it came from. So it's not all the chemotherapy, the drugs that are synthesized. But we don't, by the way, it's now synthesized. It's not that someone goes and dives in the Caribbean to find the sea squirt and extract the drug. But anyway, so I think it needs further research.
Cool. And this is one last question. I think on the chance that we get cut off, wanted to thank you so much for your time and also for your involvement in our group. Totally agree that I think the way forward for patients is advocacy, awareness, and hopefully one day a cure. The last question, I think, was like basically, what is the most up-to-date imaging protocol for myxoid liposarcoma in the thigh? It seems like there's like some disagreement between specialists about the right imaging protocol for follow-up. And I think this is probably true across lots of different subtypes that there's like some disagreement on.
Yeah, there still is disagreement. There's no uniform consensus. So, for example, on the NCCN, so I'm one of the panelists for soft tissue sarcoma, and we don't really have a clear agreement, unfortunately. So that's the best. I think what they're referring to is the staging, like how do you do a CT of the chest, you do a whole body MRI. For the primary tumor itself, so if we're talking about like it shows up in the thigh and how do we image that, that's usually MRI with contrast. But if it's for staging, the best data that we have, like people have actually, groups have actually studied this, is actually whole body MRI. So whole body MRI, but that takes it takes a long time, and then in France, unfortunately, that's the elephant in the room that I said earlier. Unfortunately, it does not. It often doesn't approve. They don't approve of whole body MRI just because of the cost.
Sounds good. All right. Well, thank you again for joining us, Dr. Tseng.
Yeah.
Thank you so much, everyone, for joining as a participant as well. We, I think many of us have heard about you and or interacted with you directly, so we appreciate you taking the time.
Yeah, of course. Thank you, everybody, and thank you, Christina. And I was going to say my email is wtseng@coh.org. Very simple, first initial, last name at coh.org. And also on Instagram too. But if you message me on Instagram, if it's getting too like confidential medical information, I'll ask you to email.
All right. Thank you.
Take care. Have a good rest of the weekend, everybody.
You too. Thanks, everyone.